Yeah. A very good evening to everybody. I'm Padmavati Krishnakumar. I'm a final year medical student from India. And also, I work as a research intern for the organization ASER for India. It is an honor to be a part of the SUCU GH 2022. And today I will be presenting the paper Strengthening Rabies Elimination Program in India, Analysis of the Current Scenario and Future Prospects. This is a paper I worked along with my colleagues from ASER, Dr. Atmika and Mr. Siddesh. Can we move on to the next slide? Next slide, please. Yes. So why did we choose to work on the rabies situation in India? As we all know, I have put up certain statistics over here. Uh, no, can you please shift to the previous slide? Uh, I have put certain statistics here on the in this slide, where have I highlighted the disease burden of rabies in India and what is the current scenario with respect to managing rabies cases. But on a personal note, because I'm a medical student, I have seen a few rabies cases in my own hospital, along with which several of my other friends who study in various medical colleges across India, they have seen certain severe rabies cases where patients have died simply because they are not aware of immediate wound management post dog bite, and they are also not aware or they're not able to seek proper timely clinical care. So, which is exactly the reason why we felt it was important to understand the scenario and recommend certain policy and implementation changes in the Indian scenario. And it should be. Can we move to the next slide? Yes. So it is very, very important to understand that rabies is not curable, but it is 100% preventable. And we believe that India should definitely harness the potential of rabies preventability. Uh, can we move to the next slide? So yes, what did we do in our study? So we basically conducted a quantitative analysis. What we did was we reviewed existing literature from India and also other low and middle income countries from Asia and Africa. We tried to find out what they did differently from India. With terms of formulating policies for rabies or for in terms of having innovative solutions to implement policy on ground to tackle the rabies disease burden. Can we move to the next slide? We found some pretty interesting things in our analysis, and one of the key things I'd like to highlight here is that in India we realize that there is no definite way to quantify the rabies disease burden at the moment. And in spite of having robust policies, we have a national rabies control program, we have the national action plan for rabies elimination. We have a lot of programs on paper, we have a lot of policies on paper, but we are not able to implement it on ground simply because we have not addressed the problems in its own unique way. And in order to do this, we believe that to facilitate the implementation of such policies in a better way, we believe we have to classify the factors that are delaying the implementation into four parts. One being patient associated, the other being healthcare sector associated, the third one being research level factors, and the last one being policy or government related factors. So as I've highlighted in the slide, I have highlighted a few points here which I felt were important for all of us to understand. In patient associated, along with the facts that I've mentioned there, I think it's also important to understand that India has a vast socio-economic and demographic differences across each region. So understanding these differences and utilizing it to our ability to ensure that everybody has equal and affordable access to be it prophylaxis, post exposure prophylaxis, or wound management, or any sort of clinical care pertaining to rabies is very important. And another point which I feel is important to understand here is that among under the lack of awareness, what a lot of people, especially in the rural areas, do is on when they immediately get a dog bite, they apply certain irritant substances to it, thinking the burning sensation or the bleeding will subside. Irritant substances could range anything from chilies to turmeric powders. Which is a wrong practice and which is influenced by cultural norms or cultural beliefs. Uh, and among in the healthcare associated factors, I think one key point I have to highlight here, besides what's mentioned, is that even in the healthcare sector, there's this common belief that rabies is a disease of the past, which is why we often underestimate its prevalence and disease burden. And as a result, there is improper training imparted right from the undergraduate to the postgraduate level, with regards to managing rabies even at peripheral centers or at higher referral centers. Another point which has to be noted is that we are not utilizing the community health workers properly. uh, Community health workers are a direct point of contact at the grassroots level to the main healthcare sector, and we have not trained them enough to identify rabies cases at the right time and refer them accordingly. In the research related factors, the major problem, as I've mentioned, is lack of funding or poor funding to develop indigenous vaccines within India. But there's also another point that I have to note is that this is directly linked to also policy related factors where researchers are not getting access to updated data on rabies prevalence. So as a result, what is happening is they are not able to understand the current scenario and state specific or a region specific scenario of rabies. And lastly, policy related factors. I have already highlighted the major points here. One key point I will be discussing in the next slide is about intersectoral coordination. Can we move to the next slide? Yeah, thank you. So, as I said, let's take it forward from the intersectoral coordination point. We will be talking about the One Health approach. As most of you might be aware, One Health approach was a modality or an approach that was introduced by the Center for Disease Control US, where they sought to understand that zoonosis infections cannot be the disease burden cannot be reduced merely by treating human cases alone, but it also involves identifying the zoonotic vector and managing their population or treating them in case they're diseased accordingly. In India, while our policy on paper again mentions that we have to follow the One Health approach to combat rabies in each state, unfortunately, it has not been put into practice as of yet. And only two pilot studies have been conducted in two different states in India, and they have found that there is a significant reduction in disease burden, especially because these states emphasized on not just treating human rabies cases, but they simultaneously and parallelly sought to reduce the stray dog population. And stray dog menace is a huge problem across every part of India. So these states, they basically went for mass sterilization programs, and if they spotted any rabid dog, they immediately maybe killed it, or they basically isolated and did whatever was needed to reduce the problem that could arise from these dogs. So that was one interesting finding about One Health approach, the pilot studies that two states had conducted in India. Another interesting finding is regarding the pre-exposure prophylaxis. While the Indian Academy of Pediatrics or the IAP schedule recommends pre-exposure prophylaxis for children, the child pediatric population, it is especially in endemic states. Unfortunately, IAP schedule is not what is standardly followed across India. The national immunization schedule is followed, and the NIS was basically developed to ensure that the basic level of vaccines are affordable to every child in this country, free of cost. And given the cost of developing pre-exposure prophylaxis vaccinations, unfortunately, the NIS schedule has not been able to accommodate this as of now. But an interesting study conducted in Philippines clearly shows that they conducted a cost benefit analysis based study basically, and they clearly showed that if you combine pre-exposure prophylaxis and post-exposure prophylaxis for children living in endemic areas, endemic rabies areas, it was found to not just be cost effective, but was also found to be beneficial for the children in terms of recovering after a dog bite, or if they've been infected with the virus. And the last approach, which was also commonly followed during pandemic in a lot of countries, including India, is the use of technology. As we all know, technology is almost there in every part of our life. Like, we are in a virtual conference right now, which shows the influence and impact technology has had in all of our lives. So we thought, why not we use this in terms of combating rabies disease burden? And turns out that a study in Tanzania exactly proves this, where they use. Hello, may I continue? Uh, okay. Can you please stay in the previous slide? Yeah. So, as I was saying, this study in Tanzania basically conducted a trial of sorts where they used the short messaging service, or the SMS service, in even peripheral health centers, where doctors and other healthcare workers could actually, on a real-time basis, report or notify rabies cases in India, rabies cases in their population. And not just that, this SMS service was also used to motivate or remind patients to go take their PEP injections on time on the particular day, on the designated days, in order to motivate them to complete the course so that they don't miss it out. And this was proven to be, this method was also very satisfactory to the participants, who were the healthcare workers and the patients alike, since it was cost effective, did not involve any unnecessary paperwork, and it was very easy. Basically, it was user friendly. So these were some of our interesting findings that we found would be useful if applied to the Indian context. This was the qualitative analysis. I've summarized it a bit. Okay, can you move to the next slide, please? Okay, so what is the way forward for India? Now, conducting this qualitative analysis for us was an eye opener, because we found some interesting ways, innovative solutions that could help us put these policies from paper to the ground level. And the way forward for India, I think at the end of the qualitative analysis, can be summarized as such. One is to seriously follow the One Health approach, where we believe that the Indian government should definitely conduct more pilot studies in each state. India has 29 states and 7 union territories, and we believe that this One Health approach related pilot studies should be conducted across each of these states, and each of these states should be encouraged to form their own One Health approach modules, so that they can focus on its capacity training, and maybe on they can have their own analysis and understanding of the animal population, and work up and integrate these two factors, the capacity training and the animal population management, accordingly, to reduce the disease burden in their respective regions. This also helps to this decentralization of policy and implementation is also beneficial to a great deal, because we have only centralized guidelines from the government, but there is no encouragement from the center to the state governments to actually formulate their own guidelines and work on it. But we believe this is one of the key steps that each state government should take to ensure that rabies is not a burden to India as a whole. Point number two, exploring the potential of pre-exposure prophylaxis in endemic areas, uh, especially for the pediatric population. We need to do more pilot studies in this area to understand its economic and cultural feasibility. But the studies from Philippines is definitely very optimistic. It's very optimistic, and we believe that we will find something if studies are done. The response to the same will be pretty much the response to the same will be will be a very good move, and we need to and we can subsequently integrate pre-exposure prophylaxis for rabies under the NIH schedule also. And one more key point, I think this is very India specific, is that we have a lot of alternative medicine healers, especially in the rural pockets. And we believe that sensitizing them and training them, to encourage people to take prophylaxis, or maybe even train them to administer the post-exposure prophylaxis, is an essential step as a way for capacity building as well. And again, one more key point I've highlighted is about stray dog population monitoring, and accordingly conducting, mass neuter spaying or sterilization program drives in order to control this population, and regularly updating dog population in each area by the municipal corporations will go a long way in reducing rabies burden. With this, I come to the end of my presentation. I thank you all for your patient listening. Uh, Please, if any questions, you can feel free to ask me. Thank you.
Thank you very much, Ms. Kumar. My name is Aaron Yamarchuk, and I've been called in to moderate this. So sorry that you had to start off by yourself, but thank you very much for starting off. And just looking for questions here. I don't see any just yet. I don't think I'm missing anything. I don't see any just yet. I guess I do have one question. So I missed the opening of your presentation. Just how severe is it? What is the situation regarding rabies in India generally?
Okay. Yeah, generally, I think I'll divide my answer for this into two parts. The first one being the data or the statistics available. So, unfortunately, in India, we are not collecting data on rabies disease burden on a regular basis. But WHO estimates that we have around India's rabies deaths contributes to roughly around 35 to 36% of the global deaths due to rabies across the world, and roughly around 59.5% to Asia's rabies related deaths. So, which is a pretty significant and scary number. And at the moment, we do have great policies, like I mentioned multiple times across my presentation, we have great policies on paper. But what happens is there's a lot of implementation delay. So that is what we sought to address in this. So, and the second part of my answer would be on a clinical, on my personal experience, I have heard of many instances where people were not aware of what to do after a dog bite, and they were not seeking post-exposure prophylaxis on time. And as a result, they unfortunately passed away. And this is a very scary scenario across a lot of places across India.
Okay.
Thank you.
Thank you very much. Seeing no other questions, we'll move on to the second presenter, who is Professor Quintin, I believe, Eichbaum. Hope I got that right. I should know it because I know you, Professor Quintin. We from numerous CUGH meetings in Washington, D.C. Professor Quintin is a professor at Vanderbilt University School of Medicine in the United States, and has been very much involved in capacity strengthening of medical schools in Southern Africa for many, many years. So it's wonderful to welcome you. We look forward to your presentation on the impact of COVID-19 pandemic on academic global health programs, results of a large international survey. Over to you.
Thank you, Aaron. Good to see you again. It's been many years. Someone said my name was showing up under another name, so I hope that's been corrected. My name is Quentin Eichbaum. I'm actually African. I was born and raised in Namibia and South Africa, and then came to the United States. So I think my slides will be run on your end because we couldn't upload them here. So I'm going to give a talk on this topic, which was a very big study, took 2 years to complete, and it almost seems now that it's published in the Annals of Global Health to be almost have historical import rather than current. But at the time it started, it was extremely relevant to everybody, and it was trying to look at the COVID-19 pandemic impact on global health academic programs. And we surveyed, next slide. So this was the study design, was a mixed method sequential explanatory design, which for those of you who have studied these methods in either medical education or other setups will see that it's quite a powerful method because it involves both quantitative, I don't know if you can see my cursor, but quantitative methods in phase 1 and then qualitative methodologies in phase 2. And so that's exactly what we did. We first had a survey, which was run in REDCap, which looked at the demographics of all the programs that we surveyed. And we surveyed 230 academic global health programs around the world, and I'll get to that. Then we looked at the educators involved in the program, the researchers involved in global health, and the administrators of global health programs. And then once we had done that phase and analyzed some of the results, we went to phase 2 and did the qualitative study and surveyed 17 people in 40-minute surveys to gain insights, explanations, as this says, to specific responses in phase 1. So this is how it's laid out here. I need to see if I can see this better. It's a bit small on my screen. So phase 1, qualitative data collection, data analysis, then you go to phase 2 and you do the interviews, and then you analyze the interviews, and then you put both phase 1 and 2 together and see what you get out of it. So it's a powerful method. Now the next slide, please. So these are the demographics. We surveyed, as I said, 230 academic global health programs in 36 countries. And some of the associations that helped us gain all these access to all these programs were the following. You can see they involve not only CUGH, but Canadian groups, the groups in Japan and AMI and a whole lot of other groups helped us access these programs. We got a pretty good spread around the world for the survey. Next slide. Next slide. So I'm going to just run through, I'll just flip through raw data, but then extract some conclusions from each of those raw data slides. This, we don't need to dwell on this much, but we wanted to see who we were dealing with. But the first thing you'll notice is, why are there so many more high academic health programs from high-income countries versus low-income countries? And that was initially a bit perplexing and disappointing, but it makes perfect sense if you think about it, because in the global south, as it's still called, you live global health. You don't need to have, so to speak, programs. Stellenbosch certainly has one, but many countries don't teach global health. They live global health. So it's a big debate raging in the whole decolonization debate, whether global health is a Western colonial construct. And so what you will naturally find is that the programs are mostly in high-income countries and less so in low and middle-income countries, but there are some. So we looked at graduate and undergraduate programs and credit bearing and international reach, and a lot of different features here which are of some interest to us but not critical for this talk. Next slide. So I'll run through some of the findings of the 3 people involved in these programs that we surveyed, which were the educators, the researchers, and the program administrators. Next slide. Here are the educators. And again, all these results have recently been published in the Annals of Global Health. Next slide. So here are some of the raw data, and I don't want to dwell too much. I'll draw attention to a few of them, but then summarize them. Question would be about whether their responses of their education programs were well or moderately well coordinated. And most people in both high and low income countries thought they were quite well coordinated, the response to COVID, 77%, 57%. A question pertaining to changes in global health education programs. These were the kinds of changes that happened. You can see they changed the delivery methods for education. Certainly they had to, because they had to move mostly to virtual, 79%, 71%. You'll see down here, they suspended outgoing travel. High-income countries had much more outgoing travel than low and middle-income countries, so 92% of programs suspended travel, and also incoming travel was suspended. Next slide. Next slide. So if you just summarize, there are many, many more data. I just showed 2 tables there. So if you look at program coordination, as I said, generally people felt they're well coordinated. There's somewhat more in LMICs thought they were not well coordinated, and reasons behind poor coordination for high-income countries were lack of central coordination or leadership support, calls and cancellations. In low-income countries, it was mostly initially struggling with education delivery and content issues. As we know, we've gotten through that, and the virtual learning has improved quite substantially as a result of the pandemic, but at the beginning, there were still issues. Distance learning was widely implemented in both high-income and low-income countries, but there were variability in preferences. Some people liked it, some don't. I think people have gotten used to it by now. Institutional funding for the education aspect of global health. HICs experienced a significant reduction, 35%. And we had to allow people, because in many countries, people don't know whether the funding has or has not been increased. So LMICs are mostly not sure whether there had been funding reductions to their education programs. Next slide. Next slide. In terms of scholarly output, it was certainly of interest to us to find out whether scholarly output how it had been impacted as a result of the pandemic. And so the number said it was considerably or moderately increased, 45% in HICs and 0 in LMICs. These are high-income countries and low and middle-income countries. You could ask, how on earth could the pandemic increase scholarly output? And the result of that, and it's certainly confirmed by submissions to journals, is people didn't have to run around and drive to work and run around doing all sorts of things at work, but educators, less so researchers in the field, could sit at home and write papers. And I know this is true because, for instance, the academic medicine told me that their submissions increased threefold during the pandemic. So 3 times as many submissions as they normally get. So it wasn't all bad news. Scholarly output in education, global health, certainly did increase. Then this is just moderately or no change. Travel certainly was impacted. High-income countries more so than low and middle-income countries, 92%, as I said. And that is simply because we over here, for colonial reasons, tend to travel more to the global south than the other way around. Next slide, please. Program coordination, I've mentioned some of this. For good coordination, what people said was good was when there was good, effective coordination versus slow decision making. There was transparency in the decision making. There was program flexibility, and there was proactive leadership that didn't just sit back but took a proactive role. Virtual learning. Oh, this is phase 2. So these are what came out of the interviews. We interviewed 17 people, each for about 40 minutes, and we had a rubric and we had specific questions, and we recorded all the comments, and we were going to do a coded analysis, as is often done in qualitative research, but we instead just did a thematic analysis because they were not the comments were not similar enough to do coding. So this is phase 2, the interviews with the subjects. These are some of the results that came out of that. Virtual learning, a few reported in the interviews big problems. And these interviews covered both high, mostly, but also low and middle income countries. Most of them predicted a hybrid model for future learning in global health. And there were some concerns with virtual platforms that came out in the interviews, and that was program accreditation, and especially a big one where clinical programs did suffer was in clinical teaching, that virtual learning is harder to do if you're not in person with your subjects. But there are platforms now that are doing more effective virtual learning. Next slide. So if we look at what were the impacts on global health researchers, this is what emerged. Next slide. These are some of the raw data, and we have lots of raw data in the paper, so I won't dwell on this too much because I've summarized the results. So the impact was very significant, more so on low and middle income countries, less so than on high income countries. And the reason for that is, I think there were funding issues, collaborations broke down. So the field research and overall research significantly affected low and middle income countries. The impact on funding, certainly none of them said funding increased, but quite a few of them had reductions, and especially, again, the reductions hit the low and middle income countries more so than high income countries. Next slide. Scholarly output in research was considerably decreased. You can moderately decreased or considerably. The scholarly output, as I alluded to earlier, in research was not increased. So certainly education had a good impact, but in research it did not have that good an impact. This is an interesting one. Could virtual collaboration replace in-person aspects of global health research? Interestingly, some people, 25% of people in low and middle income countries said virtual research collaboration could replace it, which seems a bit at odds with some of their impacts over here. So go to the next slide. I'll just, in the interest of time, summarize these results. Next slide. So here again, we just reiterated impact on research was significant for both high and low and middle income. Funding impacted low and middle income. Scholarly output decreased in low and middle income countries a lot. Also affected high income countries. And virtual collaboration, most said virtual collaboration could somewhat replace in-person collaboration. So 70%, 38% agreed on that. Next slide.
Quentin, sorry to interrupt,
yeah.
But just so you know, the third presenter isn't able to join us today, so do not feel rushed. We have plenty of time.
Oh, okay. Oh, I see. Okay. All right. That's good to know. So scholarly output, this is phase 2, the interviews from the mixed methods, sequential explanatory model, the interviews of the 17 researchers. These are some of the comments that came out of this. Every corner of research was affected. LMIC respondent said, it's too early to assess the impact. There were increased submissions, backlogged submissions, expedited of articles, expedited bypassing peer review. We all know that happened during the pandemic, that there was criticism that peer review was being bypassed in terms of getting articles quickly to print. That's an interesting ongoing debate in the whole field, because many people would argue that the peer review process is good, but it also has negative consequences in that it slows down publication of research, and journals vary enormously in how fast they get papers to print. Some take a year or even more, some are much quicker. But during the pandemic, many articles, certainly ones pertaining to COVID-19, were able, and you would read this in the New York Times, that this article was not peer-reviewed. So some people said this presented a challenge to global health scholarship standards. You know, it's an interesting question to ponder, because I think, and many of my colleagues would agree, in many ways the review process has become hit or miss. It just depends which reviewer your paper lands up with. It's a tricky setup, and I think there may be a model in which we're moving towards sort of peer review, online peer review, where you put an article up and anyone can praise it or criticize it. And Amy has some sort of models like that in one of its portals, which has pros and cons. Clinical researchers had reduced output due to increased clinical work. That was interesting. But due to the pandemic, not all, but many clinicians, certainly in the United States, and I'm sure in LMICs, their workload increased dramatically, and particularly if they were involved in treating COVID patients. So their research output, those who were doing sort of standard research, decreased. And basic scientists said they had research output prior to the vaccine when they stayed at home. They couldn't get to the laboratory, so if they were doing basic research. So most HICs and LMIs agreed that virtual research collaboration was more feasible than they previously thought, but there were drawbacks due to doing virtual collaboration. And I think we're seeing that already, that people aren't immediately getting on a plane and flying out to do something and then flying back a week later. More can be done. Data can be shared on Zoom and discussed and that. But what people missed a lot, and we all know this, was reduced social interaction, sometimes poor, but increasingly better internet connectivity, the lack of tools and resources, and this was a big one, reduced networking for collaborations and conferences. People, to my mind, in research are increasingly, or maybe always have without admitting it, gone to conferences to network and meet other people and set up collaborations. Next slide, please. So the third and last one are the administrators, and the administrators are the people who run the program. All global health programs have people who are seeing to the grants administration and the flights and the program developments and people coming in or leaving. So those are the administrators. Next slide. How did it impact them? And for them, mostly the questions pertain to risk. When would they let students and faculty go to another country, or when would they not? And so we had these divided into low risk tolerance. They're not going to let it happen unless things are secure, medium risk or high risk. Most of them were low risk. They did not want to risk things. And you've got to realize this study started sort of, I think, literally started almost, I think, only as the first vaccine was coming out, maybe even before then. So there was a very low risk tolerance for letting people go to travel. How's the decision making impacted in these programs, in global health programs? And the program's decision structure, was it centralized, decentralized, no process, or unsure? Almost most of them was a very centralized structure in the global health program. Someone at the top took that decision among the administrators, certainly, or the global health program director. Next slide. And this, I can't read through all of this, but this goes to say the way we worded some of these questions. You'll say, the program's decision criteria for resuming international exchanges. These were some of the criteria we presented them. Official international national authority travel notices and advisories are acceptable within institutional travel policies. So if this is what they wanted to see, if they would let international exchanges happen. So this is what most of them opted for. And there you can see their variety of others. A destination country has acceptably low COVID-19 incidence rate. A lot of them want that. If there's a low incidence rate, they'd be more willing to allow exchanges. Destination country has adequate public health resources to manage cases and care for individuals who may contract COVID-19, including personal protective equipment. Lack of this equipment was a big thing for those who remember in the beginning of the pandemic. Assurance that travel routes and layovers meet adequate safety criteria. Certainly people often don't travel immediately to the country, but they would have layovers in hotels, and they may be stopping in an area that had high COVID rates. So these were the ways they responded to all these kinds of risk stratifications. Next slide. Again, these just go through some more of these stratifications, but we wanted to be sure that we were teasing out, what exactly they were meaning by risk, and didn't just give one blank number. So here again, partner institution official policies are in place, and foreign visiting trainees are welcomed. So I won't read through the rest, but carry on to the next slide. So in the interview phase of this, of the administrators, where we interviewed 17 people, high-income countries, all of them except one, had low risk tolerance for international travel. Several offered trainees sort of local, which means local global health opportunities, or they pivoted to remote internships. So in their program, they just switched away from flying out and field experiences to virtual or internships within their own country. The LMICs generally had a higher, not completely, for travel overall. Medium risk depended on vaccination status, as I said on the earlier slides, adherence to safety protocols, COVID-19 testing availability, institutional committees to evaluate travel requests. So it was very interesting how different institutions all coped with the pandemic and how they viewed the risk and what they wanted there to be in place, and vaccination. So this vaccines were already available at this stage. Not the boosters, I don't think yet, but the vaccines were available. So that's how the administrators looked at this. And many programs are likely implementing and keeping this institutional memory for future pandemics. Next slide. So general comments just throughout of the interviews, through all three, through educators, administrators, and researchers. There were positive and negative comments. Overall, we were impressed by how many new and creative uses of technology there were. We were very impressed, or what came out was the dedication, and I can't say we were impressed, but what emerged from the study was the dedication, commitment of global health staff and administrators, the embracing of local student elective options, the increased focus on decolonizing global health. It's been a big movement, and there was more of an emphasis there. And I think you're going to see quite a change in the way global health is conducted in the world due to two things. One, the effects of the pandemic, and secondly, the whole equity idea in which the global north travels to the global south and not vice versa. So I think there's going to be a rethinking, and we've noticed it among our students who are thinking very carefully what they are doing in global health, and the extent to which it is colonialistic. There was a commitment to international partnerships. There's a lot of nervousness that emerged from LMICs that funding may be reduced and interest in collaboration may tail off, but I think many programs were keen to emphasize a commitment to these partnerships, and quite a few new opportunities arose as a result of the pandemic. Some of the negative impacts overall were mental health and healthcare workers. I think we've all read a lot about that. The stress on global health faculty and staff in terms of managing projects. Some of them had grants that they couldn't complete their work on, and they had deadlines, and death of global health colleagues due to COVID-19. Many programs suffered that. I think in Africa, and this talk was given at the AfriHealth meeting earlier this year as well, and we lost one of our great colleagues, James Hakim, in global health. Many of us knew him pretty well. The impact on medical student trainee clinical education, that suffered quite a lot, because you couldn't go into the wards, and students, our first and second year medical students over here, and certainly in LMICs, and those who want to travel to other countries to do more clinical work, they couldn't do it, and due to restrictions on international travel. Next slide. So the limitations of the study, every study has limitations. The low number of LMIC respondents, but as I said, that just reflects the fact that most academic global health programs are in high-income countries. So we've got to be a little cautious the extent to which we're drawing conclusions about how LMIC programs look at this. So even though we tried to go across the globe, and you saw our map, Most of the programs were in the USA still, and I think that also simply reflects the state of the programs. Most of them are still in the US. Now, the surveys were only conducted in English. We should have probably reached across other languages, French, Spanish. I mean, colonialistically, we can't even reach the 2,000 languages that were suppressed in Africa as a result of colonialism. This was a cross-sectional study. It was a 2-month survey period, data analysis for 3 months, and then the interviews were conducted. Whereas COVID-19 was a fast-changing, dynamic pandemic, and so our studies captures a point in time. We've got to be aware of that. Qualitative analysis, we didn't do a coded comment analysis, but rather just a thematic analysis. And the reason for that was it was hard to code the comments because they were all so different. So we couldn't really do a coded comment analysis in a program like NVivo or any other. Next slide. The conclusions, I could draw that some are that besides expected findings, some findings were less and unanticipated. So what emerged was the immense adaptiveness, learning agility, and innovation of programs during the pandemic, and the ready adoption of virtual learning and collaboration. These were two major findings from the study. There were certainly similarities and differences in the impact between different academic global health programs. There were definitely differences in the impact between high-income country and low- and middle-income country programs. For high-income countries, a major impact was travel restrictions, and this is mostly because the travelers being so unidirectional. For low- and middle-income countries, there was a reduction in funding, and it's hard, one has to tease apart where that reduction came from. Many programs are funded from high-income countries, but many are also locally funded, and that funding may likely have had to be siphoned to other areas. And the lack of resources to cope with the running their programs. Differences between high-income and low- and middle-income countries could be ascribed to differences in resources between the countries, established power differentials that have been entrenched through global health practices, and funding of collaborative programs that are still controlled mostly by high-income countries. That has to change. Next slide. So you could speculate what's going to happen post-pandemic. I'm not sure if we're post-pandemic yet. In the United States, there have been some surge in cases in the Northeast recently. The field of global health will be significantly transformed post-pandemic, I think, and is being transformed due to the impacts and experiences, and as I said, coupled with the move towards decolonization. Certainly an impact will be virtual communication, teaching, research will become a mainstay of global health. Changes of in-person field experiences, probably in field will decrease somewhat. I don't think it'll ever go away. It can't go away. Many students we're seeing already opting for local global health experiences instead of jumping on a plane right away. Funding may or may not decrease. I mean, I think there is a healthy shift of funding from high-income countries towards low- and middle-income countries to manage the funding wherever it comes from. Next slide. So the conclusion, finally, is that the COVID-19 pandemic disrupted academic global health programs in high and low and middle income countries in both expected and unexpected ways. Programs noted some unanticipated reductions in education program funding, negative impacts on research programs, and reduced scholarly output. I would say, as I said earlier, that in education programs, it wasn't always reduced. Many programs reported well-coordinated adaptive responses to the pandemic, for instance, virtual replacing in-person collaboration and research. This pandemic will likely have lasting impacts in global health reduction in education reduction and research collaborations with regard to education, research, and administrative program. Sorry, I've gone on longer, but I was told I could go on longer. I would have raced through it more quickly than that.
Okay, well, thank you very much for that. It was a fascinating presentation and really brought up some really interesting points. I have some questions myself, but we have two questions from the audience, and I'd like to go to those first. Yeah. So the first one is, you mentioned first of all, thank you for a wonderful presentation. And you mentioned that collaborations between high and middle, low income countries were impacted. What were the factors that impacted on successful collaboration?
Yeah, that's a very good question. Do you mean, I'm not sure if they mean with regard to just overall collaboration, that's probably what the questioner means. I think one factor was the strength of the collaboration to begin with. New partnerships probably suffered more. Partnerships that had been established over many years so that people knew each other, they knew what to do and they trusted each other, and they had, that was one factor. The second factor would be the resources available, and those resources could extend all the way from internet connectivity, programs that were maybe in very rural areas for field collaboration, that became harder, but depended on the resources available, funding and internet and all of that. And I think certainly the leadership on both sides, as I said, how proactive the leadership was in terms of adapting, whether they thought it could be done, could not be done, the level to which they were, this concept of learning agility, ready to switch. And the buzzword has become pivot, and some people have forbidden us to use the word pivot anymore. But I think it's a good question. I think a survey like this try to catch some of those factors. But I think off the top of my head and rethinking through the data, those were some of the major factors. So it would be the strength of the collaboration before the pandemic, the leadership on both sides and their adaptiveness, and the availability of resources on both sides.
Okay, thank you. The next question is, as we examine the impact of COVID, I'm curious how you define global health program. Is the definition the same in high income countries versus low middle income countries, their perspective, or rather is there a LMIC perspective post-COVID? May we want to revisit global health definition, the global health definition?
Yeah, that definition is being very seriously revisited. There have been some very scholarly articles certainly in some major journals looking at the evolution of the term global health, literally analyzing it historically and from rhetoric, and that is being done. That the term is drawing a lot of analysis and criticism, and the debate rages forth and is ongoing. And those of you who've been following the decolonization debate will know that it's a term that is being criticized. And what is the replacement term? Certainly, there's no doubt, absolutely, that global health made a very insidious switch from tropical health, which had a very colonialistic connotations, and medicine was totally implicit in colonizing and suppressing the global south end, as it's still called, and that's another debate whether that's the good term or not. Then it switched to, it had some changes, and then became international health. When I was a student at Harvard Medical School, we called it international health, and then slowly it kind of pivoted and changed around the turn of the 2000s to global health. And how and why it did that is an interesting question. I do think global health, as I said earlier, is still largely a Western colonialist construct. And I remember 10 years ago standing up at a global health meeting saying that a lot of global health is really neo-colonialistic. I mean, our metrics have changed from, instead of the amount of rubber and the amount of diamonds and the amount of, to how many students are we sending over, how many programs, how many countries do we work in, how many grants do we have, how many. This was the metrics of successful global health programs that were being used, and people didn't see the point when I was making that comparison. But global health, I go back and forth, and there's many more radical views on this. Madhu Pai's view that is, if decolonization is successful, global health should be obliterated as a discipline. I wouldn't go that far. I think a lot of good is being done. I've been thinking lately that maybe a good addition to just the word global health is equity, global health equity. The simple word equity at the end may do quite a bit to sustain the field and just keep the focus on equity, not just global health. So the second part of that question is program. And, as I said earlier, the high-income countries have programs. I mean, there's a whole cottage industry of global health programs, and it's, everyone has a program, and then some people get salaries for running the program, and you get grants for your program, and it becomes a whole self-sustaining cottage industry in the global north. And as I said earlier in the talk, the global health south lives global health. You don't necessarily need a program. And I think what you need to question, not you or what LMICs need to question, is the amount of pushback you do and whether you think there is validity in having a program or whether it just gets integrated into infectious diseases and epidemiology departments in the country. It's a moot point, is it? The other question that gets hotly debated is, are the terms global south and global north? And I think those are metaphorical terms, global south, global. They shouldn't be taken necessarily geographic. We have the global south in the global north as well. Believe me, our rural areas have global south. So you got your hand up? Or
yeah, we're at 4 o'clock. Sorry to cut you off so abruptly, but there's panel 3 and 4 coming on now.
Okay.
I don't want
All right.
So thank you very much. And
thank you, everyone. Thank you.
And thank you very much to the first presenter, Ms. Kumar, and also to you, Professor Eichbaum.
You got it right.
Thank you very much. Appreciate it.
All right. Thank you. I'll leave the session now.
Would appreciate if people complete the session evaluation and also the end of day evaluation today and tomorrow. Thank you very much, everyone.
Right. See you. Bye. Thank you. Thanks. Good questions. Bye.